Hey guys, it's me, Dr. Smeederman, Gyno Girl. Today we're going to talk about a very interesting topic that comes up in my office all the time, and it is the use of testosterone in women for sexual function. And so we're going to get deep into this discussion, which can be controversial depending on the type of testosterone you're using. And so I'll give you my take and the take of evidence-based medicine. And so let's get at it. Hey guys, it's me, Dr. Smeederman, Gyno Girl. For those of you who are new to my station, or my channel, sorry, I'm a board certified gynecologist. Actually, in August, I celebrated 9 years of private practice. And actually, if you saw my stories on Instagram, I gifted myself this beautiful pendant of the clitoris created by the amazing Sophia Wallace, who I spoke about in one of my videos on finding the clitoris and how she has been a big advocate for women's sexual health and understanding female anatomy and its role in sexual pleasure and everything like that. But anyway, it's a beautiful pendant that I've added to my stack. Everyone knows I like a little bling, so there you go. But anyway, I'm a board certified gynecologist. I have a private practice in downtown Chicago and an academic affiliation with Northwestern Feinberg School of Medicine, and I specialize in sexual medicine and menopause management, as well as pelvic pain and other things. I talk about it all here on my channel, so please like and subscribe to my channel. But today we're going to talk about a very interesting topic, and that's testosterone. And so a lot of us, when we think of testosterone, if I'm going to age myself here, is you think of these big bulky guys, you know, pump you up kind of thing. Did I just age myself with that SNL reference? But anyway, the Hans and Franz that would pump you up. Anyway, so basically testosterone is a hormone that both vulva owners and penis owners have, and it's considered a male hormone, but we have it at about a tenth of the amount that males have it. And so it is very important for women and women's sexual function. And we're going to get into why we use it and how we use it and the ins and outs around that. There was a statement put out jointly by the North American Menopause Society and the International Society for the Study of Women's Sexual Health, ISWISH and NAMS, which I talk about all the time on this channel because I'm part of both of those organizations. I'm on the board of ISWISH. I'm active in the educational committees and scientific committees for ISWISH, and then I'm going to be starting to do more with NAMS as well this year. And so there was a joint statement that was placed out on testosterone, the use of testosterone in perimenopausal and postmenopausal women. And basically, you know, we have to understand where testosterone comes from. Our ovaries make 50% of the testosterone that we use in our body, and our adrenal glands make the other 50%. So what happens in the menopause is as our ovaries retire and stop producing the hormones that they usually do, the estrogen and the testosterone, it impacts actually, you know, women's sexual function. What's interesting about testosterone, because, you know, like I said, your adrenal glands still make testosterone, just because it does plummet to a certain degree in perimenopause and menopause doesn't always mean that you're going to have symptomatology from it. Testosterone is really important in sort of regulating our sexual function. We know that it is important for, you know, when we talk about the brain being a sexual organ and how hormones impact that. Testosterone is one that puts us into an excitation mode versus an inhibition mode. When we have that excitation, you know, that's when we feel the desire. And so testosterone promotes desire. It promotes like great blood flow to the external genitals. And so at the same time promotes arousal and also orgasm. So when we have this depletion that occurs in menopause and perimenopause and the levels reduce, many times the patients are affected by it, and testosterone is one of the things that we utilize to see if we can improve women's sexual function. It's not like a silver bullet or, you know, the answer to like hypoactive sexual desire disorder or any sexual desire disorders for women, especially in the peri and postmenopause. But what I can say is that sometimes it helps patients. When we talk about HSDD, which is hypoactive sexual desire disorder, which is basically where you have a lack of desire and it bothers you or it frustrates you or you feel bad about yourself. Any of that stuff, when you lack it and you want to improve it. So if you want to have sex and you can't, then, you know, that's essentially HSDD. And that is the indication for testosterone in peri and postmenopausal women, specifically menopausal women, but I use it in transition as well. Essentially, remember that if we think about sort of, our sexual function as, desire, arousal, orgasm in a circular fashion, there are other factors that are always playing into it. So midlife women particularly, may have more stressors. I talk about this all the time. You're balancing a lot of things in the midlife. We're balancing how we feel with the emotional changes of menopause. We are balancing sort of, maybe being in the pinnacle of our careers, or, having, children that are getting older, or parents that are getting older, and you're balancing everything. And now you're dealing with this great hormonal transition that many times puts women into a spiral. And so, with this, desire goes away. I mean, if you're not sleeping because of hot flashes, or all of this, or you're in pain because of the lack of estrogen in the vulva and vagina, and this leads to sexual pain, you're not going to have the desire. So remember, when we talk about how we treat a lot of sexual medicine and sexual dysfunction, it's through a biopsychosocial model. So the biology is, there are neurotransmitters and hormones that are involved with sexual response and sexual function, but there's also social factors such as, I can give you testosterone, but I can't make you love your husband or your spouse or whatever. So, if you're really you're at odds with the person that you're having sex with, that's something that has to be addressed. That's the social. The psychological factors are like the increased anxiety, depression, all of those things that can occur, in the midlife. And so we have to address all of these. And so, testosterone's not the end all be all answer for everyone, but it definitely can help. And it helps about 50% of patients in this category. And so, what we look at are, what are the routes that we use to take it? What are the indications? What are the big side effects? In terms of indications, again, through all of the evidence that we have, we really feel that the only true indication is around sexual dysfunction and around hypoactive sexual desire disorder. That's what the data is for improvement, and so that's what we use it for. It may also help with arousal, and it may help with orgasm as well, but this is sort of the main reason that we prescribe it. And the big issues are, that come up with testosterone therapy is, are there major side effects? What's going on with the routes that we have to utilize it? The truth of the matter is there's no FDA approved version of testosterone for women. And why is that? That's a big issue that, we all struggle with, like, what's the deal with the FDA? Why do they have this going on? But with the there have been many forms that have attempted, to get FDA approved. There was like an estrogen test, but there was estrogen and testosterone in the past, which came off the market. There were testosterone patches, but it takes a lot of money and effort to get FDA approval. And if the Food and Drug Administration doesn't approve it, despite the studies that support it, I think there have been many studies, with thousands and thousands of women using this, and it was, shown to help above the placebo. But none of these methods were approved, and I don't think we'll probably get anything approved in the next few years because the attempts have been made and the FDA just, didn't approve it for one reason or another. And so what you have is, and this is why the hormone market can get very tricky, because a lot of people are sort of, predatorily trying to get, different forms of testosterone for patients without regulation. So when we're talking about the methods, a lot of my patients will come to me and they've been using pellets or, some injectables or something that were given at, some of these hormone clinics that they go to, and they pay out of pocket for it because, of course, there's no FDA approved version. The thing about when you find an FDA approved medication, a lot of negativity about big pharma, and I get it because they are a multi-billion-dollar industry, but guess what? So are supplements, so are natural products. That's also a huge industry. They're just unregulated. So the thing about, when you talk about pharmaceuticals is that we have these medications that are used, but they're studied extensively to see what their impact is on the actual patients that are using it, right? Like, this is what we use. This is the data we use to ensure that, hopefully there's going to be no negative effects or damage to you. But we don't have that with supplements or compounded things, because it's kind of like, I always describe it like for patients that use medicinal marijuana or cannabis or whatever, now in Chicago, obviously it's legal to even use, for recreational purposes. And so I tell patients like that use edibles, like, there are probably times where you try one edible, because they hear this all the time, that one edible and it feels like, okay, I'm really gonna go to sleep and it's helping my pain. And other times it feels like you're eating candy. And that's because, the cannabis market is unregulated. And so we don't have an idea if the amount that is in each is the same and how it's gonna work. And that's the whole thing with a lot of these compounded regimens that we have. With testosterone, I get it. We don't have an FDA approved version. So what do? Well, we shouldn't use something that will make us super physiologic, right? Because pellets and some of these injectables and all that stuff can give you supra physiologic doses. And so this can lead, I've had patients come in with clitoromegaly or like micro penises, like this patient, and some of this is not reversible. They'll have deeper voices or, facial hair. They feel like $1 million because you're getting this huge deal. Testosterone is still sort of a really regulated drug for men. So obviously, getting this huge boost of supra physiologic levels is going to make you feel amazing. But we do know, if you ingest testosterone orally, it can impact your cholesterol and, liver and these kind of things. So that's not the ideal route. The pellets are not the ideal route. Again, unregulated amount of testosterone, huge dosing for women that we don't need. We need about 1/10 of what men do. So how do we prescribe it? For me, I give a couple of different options for testosterone therapy for women. And one of them is, taking a male version that's FDA approved for men at their levels, such as Testim or Androgel, and titrating it to female dosing. And what I have to do always is check our, levels initially. And I check your testosterone, your sex hormone binding globulin. I talk about that as HGB in my office quite often. And, we check a free level as well. So with the testosterone, you get a total testosterone. The SHGB is your sex hormone binding globulin. You can then calculate what the free testosterone available is. So SHGB is a protein that's made in the liver. It rises with certain things like birth control or oral hormone therapy. Some patients just have more of it than others. And so this protein binds to your testosterone and doesn't make it available for the use in, say, your sexual organs or something like that. So in that respect, the SHGB is helpful to know what your baseline levels are, and we want to keep it at a physiologic premenopausal level, right? So that's kind of what we use as a baseline. And then, when I give patient a prescription for testosterone, we do transdermal route, which is absorbed through the skin. So like I said, I either use the FDA approved version for men and titrate it down to 1/10 of the dose. So if a 30-day supply of, say, 1% Testim gel for men, they have 30 packets for each patient each day. Then one of those packets that what a male patient would use for 1 day is enough for a female patient to use for 10 days. So for a 30-day supply, which isn't going to get covered by your insurance, by the way, so it's an out-of-pocket expense, you can get potentially 3 times the amount, or it can last a lot longer for most patients, depending on the dosage that they use. And so we used to use a pea-size amount, or if each packet is like 5 cc's, you can use half a cc for 10 days. Each packet should last you that long for, say, like the 1% Testim. Again, we try to titrate to 1/10 of what a man would need. And then we just follow it at 6 to 12 weeks. And if someone gets no impact on their sexual function after 3 months, then hey, you know what? It's not working for them. And we just discontinue it. Because like I said, your adrenals still make testosterone. If your levels are not low to begin with, then maybe it's not the right option for you. A transdermal route is superior based on how it impacts, it doesn't have an impact on your cholesterol or, pass through the liver, so have an impact there. It is FDA approved for their regulated systems in Europe and in Australia. So Australia has a female version of testosterone called Androphene, and I'm a registered doctor for that website, so I can prescribe through that website as well for patients who are like, I don't want to deal with this titration thing, I just want to deal with a female version. They'll order it from Australia. It'll come in the mail to them, and they just get it in the mail every couple months when they need it. And so if after, say, 3 months of being on it, they have no change in their sexual desire or sexual function, then we discontinue it. That being said, like I said, because sexual desire is so multifactorial, there are things that I can't help you with, right? Like I said, if you hate your spouse, then you need to get that taken care of. Or if you're trying to find someone new, then that's something that I can't help. But, when we also have to deal with the issues around, depression, anxiety. And also just remember, when we have a mismatch in libido, which is often the case in couples, like, the person with the hypoactive sexual desire disorder should get treated, but they're not the only ones involved in this process. And so both patient and partner should be in sex therapy and help along the process, because it's that both individuals should be treated for. But oftentimes the spouse or significant other will have their own sexual function issues as well, and so they have to be treated separately, whether or not it's another female with hyperactive sexual desire disorder, or it's like, so some of my patients are with younger patients, have mismatched desire. And then also, like, if you're male patient and you have sort of erectile issues or other things. The other thing is, like, a lot of patients, have issues around genital urinary syndrome, menopause that's untreated. And so they come with me with this lack of desire, but hey, guess what? It hurts to get penetrated. And so if your body knows that this is going to hurt every time you try it, you're not going to want to do it. So that has to be treated first, I think, so we always treat with vaginal estrogen or some affiliated version. And if there's still beyond that lacking desire, and, we've looked at sleep, we've looked at medications, we've looked at other things that might be impacting libido, relationship-wise, psychologically, like anxiety, depression, that kind of stuff, then, yes, testosterone is one of the things that we try to do and help our patients with. But again, would like to clarify and say that, it has to be in the right form. Unfortunately, we don't have an FDA approved testosterone for females in the United States, so we have to do with what we have, and we have to kind of then follow the levels to make sure you're not super physiologic, like with pellets or other things. The other dangerous thing about pellets is, like, especially when these are bioidentical, which I'll do a segment on, that are branded as such, they end up having really, like, even higher doses of estrogen than you need. So I've seen a lot of patients that develop endometrial cancer on some of these doses because, again, unregulated amounts of hormone that they're getting. I showed you the picture of the patient with the issue around her clitoris being enlarged after being on testosterone. So that is unfortunately not anything, and doesn't mean that her sexual pleasure is more either. The ins and outs around testosterone use in hypoactive sexual desire disorder, that's really the only indication. Yes, it might help your energy, it might help your muscle mass and all that good stuff, but isn't the primary indication for which we use. Be wary of someone that's going to give you those injectables or pellets that may give you really super physiologic levels and potentially cause more damage than good. But either way, it's important to see someone with a specialty in this, in sex med. You can go to the International Society for the Study of Women's Sexual Health, ishwish.org, to find someone that might help you if you're in the perimenopause, menopause. You could also look at the North American Menopause Society, which is now just the Menopause Society, and see to find someone to help you with your journey as well. But that's sort of the gist with testosterone use in women for the indication of hypoactive sexual desire disorder. So thanks for joining me today. This is again Gyno Girl, and happy to answer any questions in the comments. Take care, guys. Like and subscribe to my channel. Thanks. Bye.